half an hour, and you will be experts in TOPS. Let me kind of quickly go through the agenda, and then we'll get started. So we want to cover our clinical outcomes, case studies, maybe touch a little bit on reimbursement and next steps. And as I said, feel free to interrupt me at any point, and I will circle back to whatever questions you have. I assume everyone's familiar with TOPS. TOPS is a motion alternative to lumbar fusion, and also for decompression for patients who have stenosis and spondy. This is a PMA device that has been rigorously tested and really has proven itself not only in a clinical trial, but we're now 2 years into commercialization. And the feedback that we've been getting from doctors who've been using this device is that that the results that we had in the trial are mirroring what we see in the real world. So why decompression? That's the secret sauce here, is doctors doing a really good decompression. That's what gets these patients better. And the device basically stabilizes the segment as you would get with rigid fixation, but without sacrificing motion. Patients are encouraged to get back to normal activity. And it's that combination of the nerve root decompression with the symptoms that virtually disappear, with the immediate mobilization that get these patients very, very happy. And I think doctors are surprised and impressed with the results that we get with TOPS when they see these patients coming back at 6 weeks and 3 months. So the trial that we ran was a 300-patient trial, 2-to-1 randomized. So for every 2 TOPS, 1 fusion on patients who suffer from degen, spondy, and stenosis. Patients had to meet 6 primary endpoints. If they met all 6, that would be considered a composite clinical success. If they missed any one of them, that would be a failure. So a very, very high bar for this trial. And as you probably know, we outperformed fusion tremendously, 77 to 24. That was the basis for the FDA granting us a superiority claim. We're the only device in lumbar spine with a label of superiority to fusion. And so that should be meaningful to your customers. That superiority was driven by significant advantage for TOPS in subsequent surgical intervention, be it injection or surgery. 95% of our patients have an ODI improvement of at least 15 points. New, worse, or worsening neurodeficit, again, advantage TOPS. And this kind of funky fusion status or motion status in the TOPS arm kind of skewed the data. But if we take that specific factor out of the equation and look at just the clinically relevant endpoints, we still have a 25-point advantage for TOPS versus fusion. Obviously, the FDA looks at pre-op versus 2 years. We want to see what happens during the 2 years. And you can see here in ODI, our patients get better faster and continue to get better as you go out over the 2-year period versus fusion, which patients don't get as well as the TOPS patients. And then you see something happening around 6 months when the fusion takes hold, where this graph starts to arch back upwards. See the same thing with back pain. And again, this is not per se a solution for patients who suffer from back pain. In fact, if you have isolated back pain, I would think long and hard before using a TOPS on a patient like that. But we see for patients who have high degree of back pain, this is a very effective procedure because of the ability of this device to stabilize a segment. Many of these patients have a grade 1 spondy that's not stable, and this device will stabilize the segment. As you'd expect with these patients, they have a high degree of leg pain, and both TOPS and fusion do quite well with on that component of the outcomes. A couple interesting points in terms of secondary endpoints that also speak to the value of this device. Here you can see that we maintain preoperative motion at year 1 and 2, both in bending and in FlexX. We dial in physiological translation into the device. So this device really does mimic a facet joint. And then this is kind of surprising. You can see with the fusion cohort that all got interbodies that at 12 months, they actually had increased disc height, which is what you'd expect if you were putting an interbody. But then by 2 years, subsidence has brought them back to the same disc height. And here in the TOPS arm of the study, we basically maintain the same disc height without going into the anterior column for this patient population. Common question is, okay, what are the downsides? Obviously, there are revisions associated with TOPS, but significantly less than you have with fusion. If you look at the reasons for reoperations, they're not device related. It's a dural tear that wasn't caught intraoperatively. Surgeon had to go back and repair it. Infection. We're a teaching hospital, so 2 retained drains technically are considered a failure if you have to do a cut down incision to remove the drain. And then we did have 1 misplaced pedicle screw, less than 1% screw loosening. And if we look on the fusion arm, you can already see the beginnings of what we'd anticipate with motion preservation, which is patients who are coming back for a re-op because of adjacent segment disease in the fusion arm of the study. And that continues to hold true as we continue to follow these patients further out beyond 2 years into onto 5 years. This is some longer term data on a small cohort of patients outside the United States. This is a 11 and 12-year patient follow-up. And as you know, this is good, and this is good, and this is good, and this is good. Basically, we see patients improving in VAS, pain, SF-36. These are all older patients, and so it's nice to see, you know, a 60-year-old that comes back at the age of 71 and is still doing doing extremely well. Let's switch now to some of the case studies. I think that this is one of the primary reasons why we wanted to have this call is just to make sure everybody was kind of on the same page in terms of who are our patients. It's noteworthy that the indications for this device in the IDE were actually more narrow than the indications that we have today on label. And that was because we wanted, as part of the IDE, to study adjacent segment disease, so we didn't allow decompressions.
I'll show it to you later.
We had other constraints on the study that we simply don't have anymore. So the application of this device is, we think, relatively wide, and we'll go through some cases and also have a summary slide that'll kind of show you what you can do with this device. So this is a good example of a patient that does not have, you know, a great disc. You can see they have that kind of minimum 4 millimeters of disc height. You know, it has some serious issues in the posterior spine. This particular surgeon chose, obviously, to use TOPS and did a very, very wide decompression. Here you can see the breadth of decompression. This is a bilateral facetectomy, laminectomy. So you could appreciate that the only thing that's holding this segment stable is the TOPS device in the back. And here you can see this patient after 7 years. This patient is now out 19 years. And you can see that there's no real change in the anterior column when you have a TOPS device kind of holding that segment stable. And here you can see kind of that patient that had, you know, tremendous leg pain disappears, and the other parameters, which were not symptomatic, don't reverse. Here's a case from the IDE. This is a patient that's kind of on the other end of the spectrum, very, very tall disc, fluid in the facet capsules, coming in with preoperative scores that are in the 70s and the 80s. You could make an argument, try to, you know, decompress this patient without instrumentation, and the presumption is that patient, you know, would get better and probably house themselves somewhere in the 40s or 30s. But when you do this wide of a decompression, you really open up the entire posterior complex. There's no more nerve root impingement, and that allows the patients to get, you know, to these types of scores. And again, you know, this device is a motion preservation device by definition. But one of our doctors said, you know, we should call this product a decompression preservation device. Of course, it's a motion preserving device, but what it's really doing is preserving the doctor's decompression. So if the doctors do a good job in selecting patients and do a good job in doing the decompression, you know, we will dial in the results that they got at 6 weeks, you know, out to, you know, hopefully, you know, outlive the patient. And this is that same patient I just showed before, that obviously the segment's moving post-operatively, and the patient continues to do well. So let's talk about a couple cases from the U.S. that are kind of real world cases. And I think that these are you know, a handful of kind of interesting cases. This particular patient is suffering from L4-5 symptomatically, but you can see the 3-4 segment does not look great. In this case, the surgeon put the device in at at 4 or 5, and did some undercutting at the segment above. And the idea here is to avoid doing a single or two level fusion, and take advantage of this device's ability to protect the adjacent levels and allow you to do some level of non-destabilizing decompressive work above or below this segment. Here's another patient where if you look at the 5-1 segment, it doesn't look great. But the concern here is that if you were to fuse the 4-5 segment, it would put undue stress and strain on the 5-1 segment. High likelihood the patient would have to come back for another procedure, another fusion procedure. So maybe you're now stuck with doing a primary 2-level fusion procedure. Well, you can start this patient with with the tops at 4-5. And if you ever needed to fuse, downward, you could with this technology. And you can even see this, the surgeon did a little bit of work above this device too. So that's the beauty of this device, is it doesn't burn your last bridge. You can always convert this to a fusion, or you can combine it with a fusion down the road, and you're buying this patient some added time. And I think that's another way of looking at this technology, as a technology that may be the last surgery the patient has, but could also serve as an interim step if necessary, to ultimately a fusion if that were necessary, above or below or at the same index level. We started working with tops with robots. We've got cases with both the Mazor robot, and in this case, this was done with the Globot. These screws are off-label. These are not our screws. We did very recently get FDA approval to use Solaris screws, so that is now on label. So you can use Solaris screws with tops, and that is an on-label application. So to the extent that you have surgeons who are using Solara and like those screws, or maybe are using the robot with the Solaris screws and want to continue using the robot, we have navigation compatible instruments with our screws, but if they, again, like using Solara with the Medtronic instrumentation for navigation, you're now free and clear to combine tops with Solara screws. And this one is a little funky, maybe even questionable, so I left it for last. This is a patient who had a 3-4 fusion and a 5-1 hemilaminectomy. Now they've come back. They're suffering from DDD and instability at the 5-1 segment. And the surgeon had offered this patient essentially a 3-level fusion to go, to basically take the the 3-4 fusion and drop it all the way down to S1. The patient just did not want a 3-level fusion, and so in the end, the surgeon put kind of tops in between. So you've got a fusion below, the existing fusion above, and you've got tops in between. And basically you have a kind of a fusion that's dropping off of the tops device at the 5-1 segment. So that gives you kind of a potpourri of different ways of using tops. So kind of your bread and butter is going to be that single level spondy and stenosis. The spondy could be stable or unstable. You have patients that have multiple levels of disease where they need multiple levels of decompression, but only one level warrants instrumentation. Failed laminectomy or even a failed Coflex. We've done cases like that too, where instead of going from that failed procedure directly to an instrumented fusion, you can put tops in as that next procedure and continue to avoid fusion. Facet cysts, that's a great indication. Usually those patients have kind of a tall disc, and their pathology is purely posterior in nature. We do recommend that the surgeon, either on standing film or FlexX, try to identify some level of a slip for the purpose of being on label with that application. And then we talk about adjacent segment disease. Here's a nice example of a patient who had a previous ALIF and now has adjacent level disease a few years later above, and we drop the tops in. For those who've seen our instrumentation, very straightforward. Basically one container that houses all our instruments. We've got sterile pack TOPS devices and screws. The procedure itself is pretty akin to a straight midline open T-lift procedure, with the exception of the fact that you don't have to go into the anterior space. And for surgeons who are concerned about a learning curve, we took the first cases at every IDE site and aggregated those outcomes and compared them to all subsequent comers. And there was no statistical difference between the first patients versus the subsequent patients. So if the doctor knows how to do a decompression, knows how to put in pedicle screws, his or her first, 10th, 100th patient should all be equally as good. I'll touch quickly on issues of payment. This is the first year that the Medicare DRG flipped, and our procedure is actually more lucrative than a T-lift by about $3,000. Then for those facilities who are eligible for an NTAP payment, there's an additional up to $11,375 that can be garnered for pure Medicare patients by the hospital. And now you can create a pretty significant windfall for the hospital for their Medicare patients. Jeff Withrow is sitting right next to me. We will work with any hospital to kind of work on the economics and help them understand what their economics would look like if they were to try to go down the path of using the NTAP. This is definitely a strong selling suit for Premia and for you as you go in and talk to hospital administrators. You may even find that this is the path of least resistance, where you talk to them about, hey, let's start applying this technology in the Medicare population where there is this windfall, and then we can kind of move forward from there. On the surgeon payment side, that's a little trickier. We currently have a T code, 0202T. As everybody knows, that basically has 0 RVUs assigned to it. And so the doctor needs to perform a crosswalk. And we have obviously existing CPT-1 codes that can be used as the basis for justifying an ask of, the equivalent number of RVUs is what they get for a T-lift. And so that's our preferred method of trying to get payment for the surgeon, is by using that T code. We've got a group here in Connecticut that helps with with making sure that the paperwork is submitted properly. If there's a denial, we help with internal appeals, external appeals, and we do quite well with external appeals if the patient has a stamina to wait. So our preference is to use the T codes. We do know that there are some surgeons that are using the category 1 codes primarily. But obviously we want to keep pushing the T code. Our goal ultimately is obviously to get a category 1 code, and usage is one thing that they look for when they determine whether it's worth their while to move something from a category 3 to a category 1 code. And so that's in a nutshell, that is the story of TOPS. It is a superior solution to fusion for spondy and stenosis patients. It resonates with patients. We have about 2,000 patients every month that contact us asking for more information about the technology, and we certainly have the wherewithal to direct leads to surgeons who are in our camp, and that's been a pretty nice workflow for us and for the surgeons to get leads that come from us. Admittedly, most of these patients don't need TOPS; they need something else. But from the surgeon's perspective, a lead is a lead, and they appreciate the added benefit of working with TOPS is getting access to more patients. So I think I'll stop there, and we can answer any questions anybody has. By the way, you can kind of jot down David's email address and Jeff's email address if you've got any questions on the commercial side. And on the reimbursement side, it's Jeff W. So if it's commercial, it's Jeff A. And if it's reimbursement, it's Jeff W. So if anybody has any questions, just kind of unmute and fire away.
Hey, Ron, it's Jim Jernigan. How are you?
Yep, very good. Hey, Jim.
Good. Will we get a copy of this by chance?
Not even by chance.
Okay, good. All right, good. There are a couple of people that have been texting asking if we can have a copy of the
Absolutely.
PowerPoint.
Absolutely.
But
And
yeah, and some of the data points were fantastic. I think there was some in here that I had not seen before.
yeah, we just completed another data cut. Just got the data a week ago, and the data continues to reflect what we saw in the first cut well, obviously with a more mature patient population that's that much further down the road. So this device does well initially, and patients do well for the long term. So it really is a game changer, and I think it will become the standard of care for spondy and stenosis patients who obviously fit our indications.
Absolutely. Yeah, I was talking to the other managers earlier on. We have a scheduled call every 2 weeks, and it's just another way for us to segment the patient population, and the doctors, they like that fact because it's either right now a decompression or a fusion, and this is this offers them something that they don't have now. Are you, you're not finished, are you?
I am, unless you have more questions.
I do have another question. I thought you got approval, and maybe I missed it because I've been on the phone too, but didn't you get approval for the fusion being topped off with tops now?
So that fusion adjunct, that's the Promise extension rod, is 510(k) cleared, but not for this indication. So in other words, obviously TOPS is FDA approved,
Rerouting.
and the
Using
PR
synchronous the American Parkway
is also FDA cleared, but the combination of the two is not on label. So we can't encourage surgeons to be doing that combination procedure.
Okay. All right.
Hey, can I
Um,
clarify? Hey, Jim, it's
please.
Jeff. Good
Hey,
to see you,
Jeff.
buddy. Hey, man.
Oh my God, Jeff, how are you, man? It's been a while. Good to see you again.
Yeah, it's
Yeah.
good to see you, buddy. Were you specifically referencing adjacent level to a previous fusion, or did Ron answer your question? I want to make sure I want to clarify your question.
Well, it's kind of both, but my specific question was the two together as a solution,
Okay,
um, and that's not cleared together. I mean, now a surgeon
right.
could make the decision to do that.
Of course.
Yeah.
Yeah. Yeah. And the reason why I wanted to clarify is we've been getting a lot of questions about when they've got a previous fusion that which triggered adjacent level, right? And is it FDA approved to be able to go in and remove the hardware from the previous fusion, do a decompression at the adjacent level, and put in tops? And that is approved. So that's
Right.
part of the indication. Um, that's not widely known, and so we're trying our best to make sure people are well educated on that, because there's a lot of patients in these practices that look just like that. And so just wanted to make sure. So anyway, thanks. I just wanted to clarify, and it's once again great to see you.
Yeah. Likewise. Thank you.
Yeah.
So if there aren't any other questions, I will package this and send it over to you guys. And again, we run a lot of different programs at Premia. We have peer-to-peers where a doctor can talk to another doctor who's been using TOPS to bounce off case ideas or get some insight. So anything we can do to support you guys, let us know, and we will, we'll bring the resources to bear to make sure you guys are successful.
Thank
Hey,
you.
Ron.
That video was really good, Ron. Will it be embedded, or can you send it separately? I know that doesn't always translate when you send the PowerPoint.
Yeah, I'm gonna try to download both and then put them into a Dropbox and send them over.
Okay. Thank you.
Hey, Ron, it's Bo Ward in Columbus, Georgia. Can you hear me?
Yes.
Hey, quick question. Most of all my guys here are private. We talk about reimbursement, with RVUs versus, say, a CPT. How does that translate? Because that's the toughest conversation that I'm having with guys that are interested. It's like, well, when a CPT comes out, let me know, because I'm very interested. But, do they kind of follow the same route? as an RVU? Is, I mean, I just don't understand how that works or translates from a private position, you know, surgeon to, say, a hospital employee, this billing out through RVU.
So I can try and answer that. So I mean the short answer to the question is there is a CPT code that describes this procedure, and it's that 0202T code. Now that's a category 3 code, and there's no RVUs inherent with all category 3 codes. The same with an unlisted code. I'm sure you know your doctors are probably using on a semi-regular basis the unlisted codes, and those have no RVU, so they have to explain to the payer how much should they be getting paid. Now in Georgia, the Medicare payer in your state already has an established fee schedule for that code. So for Medicare patients, the Medicare payer in Georgia has already decided what that's going to be. And I think it's, don't quote me on this, and I can double check. I think it's in the $2,200 range, which isn't half bad at this stage of the game. Now for the commercial payers and your advantage payers, they're going to have to, just like with an unlisted code, they have to justify to that payer what they think they should be getting paid. And we provide some resources to help them make that argument to the payer. And we have folks in-house that can also work directly with those hospitals, with those doctors' practices and their coders to kind of dial in the message.
Very good. That's great info. Thank you so much. I've got a case with a surgeon this afternoon that I'll have that very conversation with, and I'll turn him to you guys when it comes to reimbursement. So
that's great.
Hey, Bo, an additional comment on that. We are having some success in that particular situation, encouraging our surgeons to negotiate RVUs with their hospitals themselves, so that equivalent to the T-lift. Because when you do the crosswalk, it should be in range of what, 48, 49 to 52 RVUs based upon those codes. And it really, if they can accomplish that, then it puts the onus primarily on the hospital from the reimbursement side. In your scenario, we got to focus on the doctor and the hospital as we're allocating resources. So this is new, but we have had some success with some surgeons who have gone ahead and negotiated that RVU schedule, once again, equivalent to the T-lift. So they get those RVUs, and then we're digging in with the hospitals to make sure they're getting reimbursed appropriate. Does that make sense?
it does.
Yeah.
Thank you, guys.
Any other questions?